The topic of my media article is vitamin D. The article I chose is titled, "Why Are So Many People Popping Vitamin D?" and it was published by the New York Times on April 10, 2017, by Gina Kolata. Through this article, several research studies were mentioned, but only two were cited fully with links, and therefore I will be discussing those. In this presentation, I will also be discussing the research studies that were mentioned in the media article and critiquing those. I will also be critiquing the media article and then discussing how a nutrition professional would deal with misinformation provided by the media and what to do when a future client brings up this information and how to address it. The first article I will be discussing is titled, "Effect of Monthly High-Dose Vitamin D Supplementation on Cardiovascular Disease in the Vitamin D Assessment Study." This was a double-blinded randomized clinical trial conducted between April 2011 and November 2012 in Auckland, New Zealand. This was conducted in response to various cohort studies that have reported increased incidence of cardiovascular disease among individuals with low vitamin D status. Currently, this research stands as significant because this information would be important in the everyday lives of individuals living with a low vitamin D status, much like ourselves in upstate New York. This would also be significant in the life of a registered dietitian to recognize the relationship between vitamin D, cardiovascular disease, and the general population. With a mean range of 65.9 years with a standard deviation of 8.3 years. After two withdrawals, there were 5,108 participants and they were separated into two groups. One group randomly received the vitamin D3 oral supplementation and the other received a placebo. The objective of the study was to examine whether monthly high-dose vitamin D supplementation prevents cardiovascular disease in the general population. The intervention consisted of an initial vitamin D3 dose of 200,000 IUs followed by 100,000 IU doses monthly, and that was continued for a median of 3.3 years. Those that were in the placebo group also had a median of 3.3 years of the consistency of the intervention. The primary outcome was the number of participants with incident cardiovascular disease and death, including a pre-specified subgroup analysis in participants with vitamin D deficiency. Secondary outcomes included some things such as myocardial infarction, heart failure, hypertension, stroke, and venous thrombosis. Some of the results of this study included that the mean baseline deseasonalized 25-hydroxyvitamin D level concentration was 26.5 nanograms per milliliter, with 1,270 participants being vitamin D deficient. In the mean follow-up of the 25-hydroxyvitamin D levels, it was greater than 20 nanograms per milliliter higher in the vitamin D group than in the placebo group. The strengths, in my opinion, are that they had good even groups between the placebo and the intervention groups. They had good sample size, and there were so many that they were continuing to be a part of the study until the end. The time of several years was beneficial to the study, but the monthly dosage seemed not to work as effectively, which brings me to what I considered weaknesses. Some of the weaknesses, in my opinion, include the location, so this can and should be done in the United States to represent the population better, versus New Zealand being from a different geographical location. This goes along with the population sample, because the participants were predominantly of European descent, and the amount of IUs and the time of it, for example, hundreds of thousands, and the time being monthly, were also weaknesses. According to the researchers, they believed that they had a high retention rate with 87% of the participants in the final follow-up period, which was one of their strengths. They had a high adherence, with 84% of capsules reported taken in questionnaires, and the mean 25-hydroxyvitamin D concentration was greater than 40 nanograms per milliliter in the vitamin D group, which confirmed the adequacy of the vitamin D dose. The weaknesses, according to the researchers, was that they had only had funding for 3 years of research. The event rate and follow-up time were lower than anticipated as well. I don't believe there were any assumptions made by the authors. For example, Robert Scrad, who is one of the professors at the University of Auckland in New Zealand, was one of the authors on this study, so I'm sure he has a background knowledge on this topic already. His background and occupation could be considered a strength to this study. I agree with the authors in their findings. The way the research was presented showed that they were evaluating baseline comparisons between the vitamin D and placebo groups, and this was effective and seemed very comparable. The researchers, however, only asked about vitamin D and calcium supplementation, and as we have learned throughout the course thus far, they play a large role in absorption, increasing bioavailability of each other, and various processes between the two vitamins. But there are also connections to other vitamins and minerals, such as magnesium, vitamin K, zinc, and vitamin A, for examples. This was significant information that they should have asked as well, because taking these vitamins and minerals may affect vitamin D. They they did not take a look at the participants' food sources, and they could have done this in the form of a food frequency questionnaire. The research was expressed in an easy-to-read and understand way, and the tables displayed did well at showing the research in a more comparable format between the vitamin D group and the placebo group. The conclusions seem to be clear, in which they state that the study found that monthly high-dose vitamin D supplementation does not prevent cardiovascular disease. I think this would have to be a weekly dosage versus a monthly dosage. Also to note, there were no conflicts of interest, and the funding did not come from a source that would have had any agenda in regards to the results of the study. The researchers did not leave any room for ambiguity as well. The second article I will be talking about is the effect of vitamin D and calcium supplementation on cancer incidence in older women. This research was conducted in 31 world countries between June 2009 and August 2015, which was the final date of follow-up. It was a double-blind, placebo-controlled, population-based randomized clinical trial. The research stands as significant because this information will be important in the everyday lives of individuals living with low vitamin D status. As mentioned before in the first article, much like ourselves in upstate New York. This would also be significant in the life of a registered dietitian to recognize the relationship between vitamin D, various cancers, and the overall population of postmenopausal women. This research was conducted because there is a considerable interest existing in the potential role for vitamin D for prevention of cancer. Garland and Gartland hypothesized the sunlight effect, in which vitamin D has a role in preventing cancer, such that those who have higher colon cancer mortality rates in the United States were located in places that have the least amount of sunlight. Since then, there have been numerous studies trying to explain the relationship between risk of cancer and sunlight exposure, or serum 25-hydroxyvitamin D levels, and there's research to claim that there could be an association. The population consisted of postmenopausal women 55 years or older in 31 different world countries, with a mean age range of 65.2 years and a standard deviation of 7 years. They used telephone calls and visit screens as ways to recruit these women. In total, there were 1,156 women in the treatment group and 1,147 in the placebo group. This allowed for fairly even group numbers and could be helpful for the results. The objective of the study was to determine if dietary supplementation of vitamin D3 and calcium reduces the risk of cancer among older women. The intervention consisted of the treatment group, which was getting the vitamin D3 and calcium supplementation, and they received 2,000 IUs per day of vitamin D and 1,500 milligrams per day of calcium, and the placebo group received identical placebos. The results of the study can be seen here with the mean baseline serum, as well as year 1, and it was not statistically significant as well. Some of the conclusions consisted of values not differing significantly between the groups, and that there were no differences observed except for the vitamin D supplementation. For example, women in the placebo group took higher amounts of vitamin D supplementation in addition to the study samples than those in the treatment group. I think the strengths are that they used an intent-to-treat analysis and a Kaplan-Meier analysis to show the difference in cancer and its significance. They were also able to use a food frequency questionnaire to evaluate the food sources that participants may include vitamin D or calcium in their diet. Because activation of vitamin D metabolism is located in the skin, kidneys, and liver, there should be more studies focusing on these organs in relation to vitamin D and cancer. Some weaknesses, in my opinion, are that they should have looked more into specific cancers in different parts of the body, because as we have learned in class, there is a correlation between the serum vitamin D levels and calcium and bone health. The strengths and weaknesses of the study, according to the researchers, was testing for serum 25-hydroxyvitamin D levels as a very available biomarker for supplement efficacy, and therefore it was a good nutrient to test for. An assumption made by the authors is that the readers knew the list of countries that they were receiving their data from, but they did not list this in their study. This could be considered a weakness because the level of vitamin D that participants could be receiving from sunlight is also dependent on their geographic location, and therefore this could be an underlying factor that they did not mention to the readers of the study. I agree with the authors of the study, however, I feel as though they could have altered the dosage to see different results. Some significant information, as I mentioned in the previous article, is that they only asked about vitamin D and calcium supplementation, as we know that other vitamins and minerals, such as magnesium, vitamin K, zinc, and vitamin A, for example, are all vitamins and minerals that affect vitamin D. The research was expressed a little cluttered in my opinion. Tables were displayed and they were easy to read, but when it came to the discussion there was a lot to discuss, and it seemed a little scattered at times. There was a clear conclusion, however, that among healthy menopausal older women, with a mean baseline serum 25-hydroxyvitamin D level, there may be the potential for ambiguity, but I don't see that being very likely as the conclusion is straightforward. The one thing to note is that the study was funded by the National Cancer Institute, and therefore it could be somewhat biased in that matter. There are many points in this article in which the author claims to raise alarm on vitamin D intake. For example, the author, Collada, mentions a study conducted in Maine. However, she does not reference the article in a long format. It is rather just to bring up the fact that individuals in the study got tested for vitamin D levels with their blood, and that 1 in 5 patients had at least one vitamin D test over a 3-year period, and they did not need to, and more than a third got 2 or more tests. The researchers who gathered the data seemed surprised by the results, but Collada mentions that perhaps they shouldn't have been. She then goes on to discuss how millions of people are popping vitamin D supplements, because they think that vitamin D will help with various health problems, such as depression, fatigue, muscle weakness, heart disease, and cancer, as have been mentioned in the 2 studies before this. There are some points in the media article when Collada mentions how there have never been widely accepted evidence that vitamin D is helpful in preventing and treating previously mentioned conditions. However, she does not cite her sources for such information. Initially, reading this article, I found it interesting that she started off with information about how people do not need vitamin D supplementation, and I thought this was the direction the media article was going. However, she then discusses information mentioning one researcher that believed just about everyone needs a vitamin D supplement, pointing out to studies suggesting an association between low vitamin D levels and higher rates of various diseases. This researcher references studies that have been too small for showing significant results of an association. But Collada says even the larger studies, such as Article 1 and Article 2, as I mentioned in this media critique, have not produced hopeful results. Many research papers begin describing the results of vitamin D levels in various health conditions, and therefore the testing and studies took off, as Collada states. I think the point of this was to state that sometimes the media creates this position on a subject, such as vitamin D, being something everyone needs to be taking, because we are all deficient in this vitamin, and that as a reader you need to do your research. Too many people are using blood testing to see their vitamin D levels, as she states, and many clinicians are recommending it as well. And quotes a nurse specifically who says that she can see how many people are getting persuaded to get blood testing done for vitamin D. Collada has a background in science and medicine and has studied molecular biology from MIT and then went to University of Maryland to obtain her master's in applied mathematics. She seems to have some knowledge on vitamin D, and I do agree with how much information she gave on both. Sometimes clients of registered dietitians get misinformed by the media articles that they read online or in newspapers or they hear on the news. It's important to read the studies referenced in the media articles because they may not be representative of the overall population or even the population that they come from. For example, in Study 1, we saw that the population was from New Zealand and that they only included between specific ages. It's important to make sure that the population is representative of what your geographical location is, and also the customs in regards to food, because different countries have different food sources and availability. It's also important to learn about the author and their background on the topic to make sure that they're reputable and know what they're talking about. And lastly, there's a plethora of information online, so take the time to read peer-reviewed articles to make sure you understand various studies that have been talked about in specific association or relationship, such as vitamin D to cancer and cardiovascular health. And lastly, you will see my references located on this slide, the first one being the media article that I mentioned, and the 2 others are the research articles that were mentioned in the media piece, and I appreciate you taking the time to listen to this media article critique.